Welcome to today's deep dive. We're tackling a topic today that affects literally millions of people, but it's one that is rarely discussed openly.
Right, definitely a topic surrounded by a lot of silence.
Yeah, so much violence. We're talking about genitourinary syndrome of menopause, or GSM for short. We're looking at vaginal dryness and the very real, often misunderstood science behind intimacy aids.
And we have a really solid stack of sources for this one.
We do. We're pulling from clinical guidelines from the British Menopause Society, recommendations from the NHS, recent urogynecology research, and even some pelvic floor physical therapy manuals.
It's a lot of ground to cover.
It is. But the mission for this deep dive is pretty straightforward. We want to decode this incredibly overwhelming world of intimacy aids. I mean, everything from lubricants and moisturizers to dilators and vibrators.
Which is so needed.
Exactly. We want to give you a scientific, highly practical roadmap to reclaiming pelvic comfort and sexual health.
And we really need a roadmap, Because usually when you step into a pharmacy to solve a medical issue, you expect some level of precision.
Oh, for sure. Like, you have a headache, you grab ibuprofen.
Right. You have a cut, you grab a bandage. The solutions are categorized, visible, and just straightforward.
But if you wander into the personal care aisle looking for solutions for pelvic discomfort, that precision just entirely vanishes.
It's completely gone.
You find yourself staring at this wall of brightly colored bottles, vague wellness buzzwords, and these marketing claims that tell you almost nothing about the actual biology of what you're holding in your hand.
It's essentially the definition of diagnostic muddy waters for anyone navigating GSM.
Totally.
So to navigate those waters, we have to start by understanding the landscape of the body itself. GSM isn't just a single symptom that you can slap a Band-Aid on.
Right.
It is a profound biological shift affecting the vulva, the vagina, and the lower urinary tract. And it's typically triggered by a significant drop in estrogen.
Which we see most commonly during menopause, obviously.
Yes, but it also happens postpartum or, following certain cancer treatments.
Okay, let's unpack this. Because when that estrogen drops, the actual architecture of the tissue itself completely transforms.
It really does.
The clinical sources describe this in such vivid detail. Without a steady supply of estrogen, the vaginal lining visibly changes. It becomes thinner, paler, and it loses collagen.
And crucially, it loses its rugae.
Yes,
Mm-hmm.
the rugae. Those are the natural, accordion-like ridges lining the vaginal canal, right?
Exactly. They allow the tissue to stretch and expand comfortably during movement or intimacy.
And once those flatten out, the tissue just fundamentally loses its elasticity.
Which perfectly explains the mechanical discomfort people feel. But if we connect this to the bigger picture, what happens at a microscopic level is even more disruptive.
Oh, the microbiome stuff.
Yes. Estrogen acts as the primary fuel source for the lactobacilli in the vaginal microbiome. Those are your resident good bacteria.
They act almost like microscopic peacekeepers, right? For that entire ecosystem.
They absolutely do. They are constantly producing lactic acid, which keeps the vaginal environment at a very specific, protective, acidic pH, usually sitting tightly between 3.5 and 4.5.
So it's pretty acidic.
Very. But when estrogen drops, those lactobacilli are essentially starved of their fuel.
Oh, wow.
Yeah, so as their population declines, the lactic acid production just plummets. And without that acid, the pH of the vagina shoots up. It shifts from that protective acidic state to an alkaline state, often hitting 5.0 or much higher.
Which basically rolls out the red carpet for opportunistic bad bacteria to just move in and set up camp.
Exactly. That alkaline shift completely compromises the tissue's protective barrier. This is why people dealing with GSM don't just experience a lack of moisture.
Right, it's not just dryness.
Right. They suddenly find themselves battling chronic irritation, bacterial vaginosis, and recurring urinary tract infections. The entire chemical defense system has been dismantled.
I really want to pause on the daily lived experience of this because the sources point out how much unnecessary shame gets attached to these symptoms.
It's heartbreaking, really.
It is. People internalize the dryness or the pain. They blame themselves for a loss of arousal. Or they convince themselves that a lack of physical response is like a psychological failing. Or somehow a reflection of their relationship.
Which is so far from the truth.
Right. I mean, think about trying to grow a lush, thriving garden in soil that has had every single drop of water and nutrient chemically stripped away.
You wouldn't blame the plants for wilting.
Exactly. You would look at the altered soil. This is a purely biological, cellular reality.
The drought is a measurable anatomical and chemical event. It has literally nothing to do with desire or your psychological state.
So if we establish that the biological soil is dry, the next logical question is, how do we effectively and safely artificially replace that moisture?
And the immediate instinct is usually just to grab the first bottle off that overwhelming pharmacy shelf.
But our stack of research makes it terrifyingly clear that choosing the wrong bottle can actually amplify the damage.
Yeah, we have to address a massive industry-wide misconception that causes so much of this accidental damage.
The terminology, right.
Yes. The terms lubricant and moisturizer are used completely interchangeably in marketing and in casual conversation. But biologically speaking, they serve entirely different, almost opposite functions.
Reading through the physical therapy guidelines, the clearest analogy is standard lip care.
Oh, that's a good way to look at it.
Yeah. A lubricant is basically lip gloss. You apply it in the moment to get immediate slip and to reduce surface friction right then and there. But it just sits on top of the tissue.
Right, it's temporary.
Exactly.
Right. Vaginal.
Moisturizer, on the other hand, is your daily, deeply hydrating lip balm. You use it regularly, completely independent of intimacy, to actively heal and rehydrate the underlying cellular tissue over time.
Because a moisturizer is formulated to actually change the fluid content of the epithelial cells over a period of days. You really need both tools in your toolkit. However, we really need to put those lip glosses, the lubricants, under a microscope, because the chemistry of what makes them slippery is where the hidden danger lies.
Here's where it gets really interesting, and it requires us to become like ingredient detectives. The sources spend a lot of time on a concept called osmolality.
Yes, osmolality is a critical metric. Simply put, it is a measure of concentration.
Okay.
It refers to the number of dissolved particles, so things like sugars, salts, or synthetic thickeners that are floating around inside a liquid.
So it's basically a measurement of how crowded the liquid is with extra ingredients.
That is a great way to picture it. Now, human cells have their own natural internal osmolality, usually sitting around 280 to 310 millismoles per kilogram.
Okay, 280 to 310, got it.
And nature always demands balance. When you introduce a liquid with a highly concentrated particle count, meaning a high osmolality, onto a sensitive, semi-permeable human tissue like the vaginal wall, the environment immediately tries to equalize.
To balance out the crowding.
Exactly. So to dilute that heavily concentrated lubricant, the lubricant will actively pull water out of your own vaginal cells.
Wait, really? It literally sucks the intrinsic moisture out of your delicate tissue just to water itself down.
Yes, it pulls it right out.
That is incredibly counterproductive.
It is. It causes the epithelial cells to rapidly dehydrate and shrivel. And in severe cases, because the cells have been drained of their structural integrity, the entire top layer of the vaginal lining will slough off.
Oh, wow. That sounds painful.
It leaves the underlying tissue completely exposed, incredibly vulnerable to microtears, and dramatically increases the risk of those alkaline-driven infections we just talked about.
Knowing the mechanism of how that cellular damage happens makes the data in these sources genuinely shocking. I mean, the World Health Organization has clear guidelines stating that for safety, personal lubricants should have an osmolality below 1200.
But ideally right in that natural human range of around 300.
Right. Yet when researchers tested massive commercial bestsellers, the numbers were just off the charts. Astroglide liquid, for example, a product you can find in almost every drugstore in the world, clocked in at over 8,000 millismoles per kilogram.
It's staggering. You apply a product expecting it to relieve dryness, and chemically, you are inducing severe cellular dehydration.
So what are the specific red flags you should be scanning the back of the bottle for to avoid this osmotic trap?
The primary culprit driving osmolality through the roof is glycerin, which is sometimes listed as glycerol.
Okay, watch out for glycerin.
Right. It's a very cheap sugar alcohol utilized by manufacturers because it makes the product feel slippery and prevents it from drying out on the shelf.
But internally?
Internally, high levels of glycerin not only dehydrate the tissue through that osmotic pull, they literally act as a food source for yeast.
Yikes. So it's basically feeding a potential infection.
Exactly. You also need to actively avoid propylene glycol, parabens, and anything marketed with warming or tingling effects.
Yeah, the sources were clear on that. Those tingling agents aren't magic. They're essentially just mild chemical irritants, deliberately causing localized inflammation to simulate blood flow.
Exactly.
And applying chemical irritants is the absolute last thing fragile, thinning GSM tissue needs.
For genuine safety, you should be seeking out low osmolality water-based formulas. Look for ingredients like hyaluronic acid, which naturally binds moisture to the tissue without creating osmotic stress.
Or silicone, right?
Yes, alternatively, high-quality silicone lubricants are an excellent choice for intimacy. Silicone molecules are physically too large to be absorbed by human cells at all.
Oh, so they can't cause that osmotic pull.
Right. They simply sit on the surface, providing a long-lasting, frictionless barrier without ever interfering with your cellular water balance.
Okay, so navigating the liquids correctly, using a daily moisturizer for cellular health, and a safe, low osmolality silicone lube for friction that can absolutely solve the mucosal surface issues.
But there's more to it.
There is. As we move into the urogynecology reports, a much deeper issue emerges. If penetration or daily movement has been painful for months or years due to that surface dryness, the pelvic floor muscles underneath don't just ignore it.
No, they react.
Right, they start guarding against the pain, eventually developing chronic tension, tight trigger points, and sometimes even scar tissue. And a high-quality silicone lube cannot undo a deep muscle spasm.
When the problem progresses from the surface mucosa down into the musculature, liquids are no longer enough. You have to look at physical tools, what we might call the hardware, to retrain that anatomical response.
Which brings us to vaginal dilators. And, I think a lot of people hear the word dilator and picture some medieval medical instrument, or they mistakenly confuse them with novelty adult toys.
Which they aren't.
No. The clinical guidelines from the NHS explicitly recommend these as validated essential medical devices.
Dilators are typically smooth cylinders made of medical-grade silicone or rigid plastic, and they come in a set of progressively larger sizes. They are the gold standard physical therapy treatment for conditions like vaginismus, which is that involuntary muscle spasm, as well as for breaking down post-surgical scarring, recovering from pelvic radiation, and managing the severe loss of elasticity we see with GSM.
Wait, I need to push back on the mechanics of this a little bit, because they just look like static cylinders. If the issue is severe muscle tension and guarding, how does inserting a rigid piece of silicone actually force a muscle to relax? Aren't you just aggressively stretching out a tight muscle, like forcing a tight hamstring to stretch?
It's a really common assumption, but the mechanism is actually much more neurological than mechanical stretching.
Oh, really?
Yeah. When penetration has been painful for a long time, your brain wires a highly efficient reflex arc. It learns that insertion equals pain. Therefore, it automatically contracts the pelvic floor muscles to protect the body.
So it's anticipating the pain.
Exactly. Dilators work by interrupting and rewriting that neurological loop. By inserting a small, completely non-threatening object while consciously practicing physical relaxation and diaphragmatic breathing, you are actively retraining the nervous system.
You're proving to the brain that it's safe.
Yes, you are proving it is safe to allow those muscles to lengthen rather than reflexively clamping down.
And the instructions provided in the physiotherapy sources emphasize that this is very deliberate practice. You don't just endure it.
No, absolutely not.
You always start with the smallest size, which is often no thicker than a pinky finger. You use a generous amount of safe lubricant, and you hold the dilator in place for like 5 to 10 minutes, while focusing entirely on releasing tension through your breath.
There is a vital metric in those guidelines to follow too, the 3 out of 10 rule.
Right, the pain scale.
When you are doing dilator therapy, mild pressure or a gentle feeling of stretching is totally normal. But if the discomfort ever crosses into actual pain, anything above a 3 or a 4 on a standard 10-point pain scale, you must stop immediately or size down.
Because if you grit your teeth and push through severe pain, you're just proving your brain right.
Exactly.
You're reinforcing the exact trauma and guarding response you were trying to cure.
It requires immense patience and self-compassion. You only progress to the next size up when the current one is completely comfortable and, honestly, boring.
Now, dilators make sense for general capacity and retraining the whole muscular ring. But what if the pain is highly localized? Like, what if there is a specific sharp knot of muscle pain deep inside that is causing the dysfunction?
That is where the sources introduce pelvic floor wands.
Yeah, I was looking at the design of the wands from Intimate Rose, which were designed by a pelvic physical therapist, and it's a brilliant piece of engineering. It essentially acts as a highly specific internal foam roller for the pelvic floor.
A wand serves a very different anatomical purpose than a dilator. A wand is typically curved, almost like a subtle S shape, with tapered ends.
Kind of like a hook.
Yeah. It is designed to bypass the general tissue and specifically target deep muscle knots and trigger points. Conditions like endometriosis, interstitial cystitis, or chronic pelvic pain often result in hypertonic muscle bands.
Which are basically severe, localized cramps that just never fully release.
Right.
It's exactly like when you have a stubborn knot tucked under your shoulder blade and you need a massage therapist to press their thumb right into that specific agonizing spot and just hold it there until the muscle finally gives up and melts.
The underlying physiology is identical. A pelvic wand allows a patient to reach those internal trigger points themselves. They can apply gentle, sustained pressure directly to the hypertonic band.
And holding that pressure is key, right?
Yes, by holding that pressure, it cuts off the localized blood flow for just a moment. And when the pressure is released, fresh, oxygenated blood rushes in, which physically forces the muscle fibers to unclench.
And if you're listening to this and thinking, I barely have time to make coffee, I definitely do not have time for a 30-minute internal physical therapy session every day.
Well, the research actually highlights that even 5 minutes of targeted trigger point release with a wand can dramatically break the cycle of chronic muscle guarding.
So you don't need hours. You just need consistency.
Consistency is key. But while dilators and wands are incredibly effective, they do require active, conscious effort. The process can feel very clinical, somewhat tedious, and it requires a lot of focus on physical mechanics.
So what if there was a tool that bridged the gap between rigorous medical therapy and actual passive pleasure? A tool that didn't require you to manually hunt down trigger points, but instead actively tricked your entire nervous system into relaxing.
Which brings us to perhaps the most misunderstood and stigmatized medical device in modern history.
The vibrator. And I have to admit, reading the historical research from the Sexual Medicine Society of North America completely blew my mind. Vibrators were not invented as novelty sex toys.
No, they were not.
They were invented in the early 1900s, right at the dawn of widespread electrical power, as legitimate, heavy-duty medical devices. They were standard equipment kept in physicians' offices as a cutting-edge treatment for pelvic massage.
They were highly regarded by Western medicine. Doctors recognized their therapeutic value for pelvic health long before they entered the public sphere.
So how did a piece of standard medical equipment end up banished to the, neon-lit back rooms of novelty shops?
The shift happened in the 1920s when early motion picture pornography began featuring vibrators on screen.
Ah, of course.
Yeah, the moment these clinical devices were visibly associated with sex work and pornography, the medical establishment panicked. Driven by intense societal stigma and puritanical taboos, doctors universally abandoned them to protect their professional reputations.
That's wild.
They became tied entirely to sexual deviancy, and their legitimate therapeutic value was quietly erased from medical textbooks for almost a century.
Which is an absolute tragedy for women's health. Because, as the modern urogynecology sources point out, we are finally coming full circle to realize what those 1900s doctors intuitively knew. From a purely neurological and physiological standpoint, targeted vibration is profound medicine for a dysfunctional pelvic floor.
What's fascinating here is the underlying neurology that makes vibration so effective. It comes down to a physiological mechanism known as gate control theory.
I love this concept. Explain how the neurological gate works.
Think of your spinal cord as a literal gatekeeper that can only process a finite amount of sensory information traveling to the brain at one time.
Okay.
Pain signals, like the burning of GSM or the cramping of a pelvic spasm, they travel along certain relatively slow nerve fibers.
Right.
However, vibration and pressure signals travel along entirely different, much faster, thicker nerve fibers. Because the vibration signals reach the brain faster and in a much greater volume, they effectively close the gate to the slower pain signals trying to get through.
So by introducing a strong, steady vibration, you are essentially overwhelming the brain's sensory switchboard with a pleasant or neutral sensation, physically blocking the pain signals from ever registering in the brain.
That is the exact mechanism. A vibrating tool, whether it's a vibrating pelvic wand targeting a specific knot, a vibrating dilator, or just a small external clitoral massager, it floods the entire pelvic region with non-painful stimuli.
Which tricks the nervous system.
Yes. This neurological trick forces the pelvic muscles to drop their guard and relax, allowing patients to accept penetration, therapy, or intimacy without the body spasming in self-defense.
And beyond the neurological trickery, the vibration physically changes the environment of the tissue itself, Localized vibration drastically increases blood flow to the immediate area.
Exactly.
And more blood means a massive influx of oxygen and nutrients, which actively nourishes those thinning vaginal tissues. It encourages rapid cellular regeneration, and it naturally increases the body's own lubricative response.
It's all connected.
So what does this all mean? When you put it all together, the hormonal shifts, the osmolality data, the neurological reflex arcs, what is the big takeaway for someone listening who has been suffering through GSM, painful intimacy, or pelvic tension in silence?
It means we have to completely reframe how we view these products and tools. A vibrator isn't just a taboo toy. It is a valid, doctor-recommended medical instrument for increasing blood flow and down-regulating pain pathways.
Right.
A dilator isn't an instrument of torture. It's a vital physical therapy tool for retraining your brain. And a moisturizer isn't a luxury item. It is necessary cellular hydration for altered tissue. GSM is a biological reality, but more importantly, it is a highly treatable one.
You do not have to just accept pain or discomfort as an inevitable byproduct of aging or hormonal changes. You just have to be incredibly smart about the tools you choose. You have to become an ingredient detective, scour those labels, watch out for that high osmolality and yeast-feeding glycerin. Treat your daily vaginal moisturizer exactly like you treat your daily face cream. And save the low osmolality, safe silicone lubricants for when you need that immediate surface slip. And most importantly, give yourself the grace and permission to use the hardware, the wands, the dilators, the vibrators, to gently retrain your body.
This raises an important question to leave you with, one that really builds on everything we've uncovered today. We just discussed how the entire medical establishment abandoned the vibrator in the 1920s purely due to societal stigma, leaving millions of patients to suffer with pelvic pain in silence for a century.
A whole century.
Yeah. And with modern artificial intelligence now capable of rapidly scanning and analyzing thousands of discarded pre-1920s medical textbooks and clinical journals, it really makes you wonder.
Oh, that's interesting.
What other highly effective treatments for women's health were abandoned due to historical puritanism, just waiting for an algorithm to flag them as neurologically brilliant for modern medicine to rediscover?
That is a thought worth keeping front of mind. Because when we clear away the stigma and look at the raw data, the solutions to our most private pain are often hiding right in front of us. Thank you for joining us on this deep dive. Keep questioning the labels on your products, keep exploring the science behind your body, and never stop advocating for your own comfort and health.